with the C0-C1. So our hand placement of our short applicator is going to be over, I should say, above the ear, right? So it's going to be like that. It's going to be high. Simultaneously, the other thing that's going to be high is our arc of rotation. Traditionally, this is done with a chin grip. Can be done with the cradle grip as well. For all intents and purposes, I'm going to show it with the chin grip. Okay, so the other thing that we had spoke about that we didn't quite get to was identifying your segment layer, right, or your target level. Okay, so we'll briefly run through that, and then we'll go right into our C0-C1. So we spoke about the Fernandez de la Peña study where they looked at the lateral glide and then validated that against a dynamic it was I believe it was an X-ray where they had them flex and extend and looked at the hypomobile segments. Okay, so for me, I imagine my hands become paddles, right? And my contact points are going to be on the articular the articular pads and on the articular pillars of the neck. So I'm going to come in, just be starting at the occiput, and then I'm going to gently move side to side as I come down the neck. Okay, and in the paper, what they suggest would be I'm going to push in, looking for any resistance on the pushing, any abnormal resistance at the end range, and then its ability to come back, as well as any subjective report of symptoms. And you can alternate, suggesting that I'm at one level and I'm going to check the right side, and then I'm going to check the left side. Check the right side, check the left side. If I come to any adverse response of the three that I've already mentioned, as far as the initial resistance, the end range resistance, and or symptoms, then I'm going to extend, repeat the lateral glide, and then flex at that level and repeat to otherwise check my findings. I would repeat that all the way up, or in this case all the way down, and then all the way back up the cervical spine. And that again has shown to be very effective at being as its correlation relative to advanced imaging. Now, the most important thing, as I mentioned, is that it needs to give you the information that you need to reliably and accurately identify those areas of tension. Your criteria on validity here is going to be the patient's report of, yes, that, oh yeah, that is my symptoms, or that is a stiff segment relative to the one up or below. Okay. The other technique that I utilize is similar to the vectors that we put in place for our cervical spine high velocity, low amplitude thrust mobilizations, where it's a combined movement. So if I'm going to assess the right side of the spine, I'm going to start up at the occiput, and it's got this kind of side bend, lateral glide motion, right? And I use the analogy of what was your analogy, Runa? Cycling, yeah. She said cycling. I like to think of it as like more of a like a moonwalk or a dance, right? Where it really, and from the patient, it should be relatively comfortable. Where this hand is just kind of reciprocating what this hand is feeling as I kind of start at the occiput. Yep. So I side bend, rotate, extend. Side bend, rotate, extend. Side bend, rotate, extend. And I just gently work down the spine. Same thing, I'm kind of taking up that tissue slack laterally from the midline, which again gives me still an accurate feel as to what the joints are doing, but it also makes it for a more comfortable experience. If I was to show on this side, again, it would be side bend, rotation, extension. Side bend, rotation, extension. Side bend, rotation, extension. And then I'll come back in and I'm like, oh, you know what, it's stiff there. And then this one moves pretty well, that one, okay. And then, yeah, I think it's good that we're working on Kobe's upper cervical, because that OA and I would even say the left side maybe more, or the right side a little bit more than the left. So those are the two techniques that I have come to in my clinical practice. It gives me all the information that I otherwise need. And I suggest you either practice those techniques or otherwise find your own, as long as it's reliable and as far as like your consistent findings and it gives you the information that you need. I would just encourage you to be consistent regardless. Okay, so using our techniques, we identified the areas in question. In this case, we're going to target the upper cervical spine, that is C0-C1. You can also assess this joint in a couple different ways. If we're pulling from the SFMA, right, they would essentially take up the tissue slack of the occiput by rotating him fully and then having him nod. Okay, you can appreciate there's not much movement there. I would expect his mandible to deviate by 20 degrees. 28 degrees is not a lot, but it's more than what he demonstrated, right? So he's definitely stiff in that regard. It doesn't really tell you which side, because they both need a nod, but this is better when he rotates that way. So I can otherwise assess a little bit as to which side it is by getting a sense of capital extension and capital flexion, as well as with the technique that I just demonstrated, right? And they talk about the mia and the ellipse, right? So such that if I, this condyle is gonna go medial, inferior, and anterior, while the right one goes lateral, posterior, and superior, right? And so I can get in and say, okay, that's all right. That's, again, I still feel the restriction a little bit more on the left in this case with that movement than the other. Kobe, what do you feel?
Yeah, left side.
Yeah, okay. Well, that bodes well for us because that's the side we're about to target. Okay, so chin cradle grip. We're going to move him to the side of the table. I'm going to lay down my forearm and roll his head onto it. It's free rotation. I don't need to do anything else except for move his head. We do need those 5 points of contact: finger, palm, forearm, bicep, and then pec. And it would be like this. Again, we're not strangling him. It's just a little bit of fingertip contact around the mandible. Okay, and I need to make sure that I can side bend. I need to make sure that I can rotate, and I need to make sure that I can side glide independent of my short lever. I need to get a little bit more underneath him. Okay, very good. So there's my rotation. I side bend, side glide. I need a little bit more side bend. So rotate, side bend, side glide, and I poke the chin up, and then I thrust. And the technique for the actual thrust is like this, right? So it's whether you want to think of it as, I don't know, the analogies that people have described, right? It's kind of like that monkey fart motion. For those in like northern climates, right? It's like also like scooping snow and throwing it over your shoulder, but it's that motion.